Okay. So once again, ladies and gentlemen, welcome to the next part of this webinar, which is the college lecture. Now, as has been customary over the last, from the beginning of this year, the Ceylon College of Physicians conducts the college lecture in collaboration with one of the sister societies. And today, our collaboration is with the Sri Lanka Society of Nephrology. And we have a speaker who is a consultant nephrologist, Dr. Chathurika Beligaswatta, who is going to speak on kidneys in the time of COVID-19. I would like to welcome warmly my colleague, Dr. Anura Hevagigana, who is president of the Sri Lanka Society of Nephrology. Thank you, Anura, for joining us and spending your valuable time here. May I hand the microphone over to you to introduce the speaker and start the session?
Thank you, Professor Rajapaksha. Today, we are having Dr. Chathurika Beligaswatta, one of our junior colleagues, and an active member in the Society of Nephrology for the college lecture on kidneys in the time of COVID-19. Over to you, Chathurika.
Thank you very much. First of all, I would like to thank Ceylon College of Physicians and Sri Lanka Society of Nephrology for giving me this opportunity to talk on a very timely topic, that is kidneys in the time of COVID-19. So half an hour would not be sufficient for me to go through all important areas that come under this broad topic, but I would try my best to briefly touch upon the important areas in the next half an hour or so. So let me take you through the outline of my talk today. So I would be talking to you about acute kidney injury in COVID-19 patients, a little bit about the prevalence, pathophysiology, the histopathological patterns, and the prevention and management of COVID-related acute kidney injury. And the guidelines available for us for the management of transplant patients with COVID-19 and the timing of transplantation if prospective recipient or donor becomes positive for COVID-19, and the current statements and guidelines on vaccination of CKD and transplant patients and their outcomes, and vaccination of patients who are on immunomodulatory drugs, and a little bit about post-acute COVID-19 syndrome and renal sequelae. So as we all know, severe acute respiratory syndrome coronavirus 2 is a virus responsible for coronavirus disease 2019, which is well known as COVID-19. So it bears some resemblance to two other life-threatening coronavirus infections, which were seen recently, the SARS, which was seen in 2002, 2003, and the MERS, which was known as Middle East Respiratory Syndrome, which was seen in 2012. And both these illnesses cause severe respiratory symptoms in humans, and all of these three infectious diseases are caused by beta coronaviruses. The clinical spectrum of COVID-19 illness is quite broad. It ranges from an asymptomatic response or development of a very mild upper respiratory tract infection to a very critical illness with multi-organ involvement. So it's now recognized as a multi-organ disease. So what are the organs that are affected by COVID-19? So as we all know, it predominantly affects the lungs in infected patients. But as I mentioned earlier, it's a multi-organ disease, and it's well known to affect other organ systems apart from the respiratory system. And kidney is one of the commonest organs affected in hospitalized patients with COVID-19. And apart from the kidney, there are many other organ systems which are involved: the gastrointestinal system, the endocrine system, the heart, the nervous system, the eyes, and the skin. So I'm going to talk to you about the acute kidney injury in COVID-19. So it's now recognized as a very common complication of the disease and is often evident at the time of admission to hospitals. And patients with COVID-19 who develop acute kidney injury are more likely to be admitted to the ICU and require mechanical ventilation and also the support of vasopressors than patients who do not develop acute kidney injury. And if you look at the mortality of these patients who have COVID-19 associated AKI, it's higher than those without kidney involvement. And the mortality among hospitalized patients with COVID-19 associated AKI roughly comes to about 35 to 80%. And the mortality among patients who are admitted to ICU with COVID-19 AKI who also require kidney replacement therapy, especially higher than that, and it reaches 75 to 90%. earlier studies from Wuhan, China did not reveal very high rates of kidney involvement, but subsequent studies done in Europe and USA revealed higher rates of acute kidney injury in hospitalized patients with COVID-19. And the most recent data suggests that the prevalence of AKI in hospitalized COVID-19 patients ranges between 30 to 50%. So these are some studies which have been done in the recent past and published in Kidney International. So this is a retrospective cohort study which was done in 13 hospitals in New York. And they looked at about 5,449 patients who were hospitalized with COVID-19. And they came to a conclusion, or they could find out that acute kidney injury was prevalent in about 37% of patients hospitalized with COVID-19. So roughly about 1/3 of patients who are hospitalized with COVID-19 end up with acute kidney injury. And out of these patients, about 50% roughly, that is half of these patients, end up with mild forms of AKI, usually stage 1 AKI, whereas the rest of the cases end up with more severe forms of AKI that include stage 2 and stage 3 AKI. And in this study, they also found out something very interesting. That was that there was substantial clustering of events related to AKI at the time of intubation and initiation of mechanical ventilation. So the case rates were higher at the time of intubation of these patients and at the time of initiation of mechanical ventilation. And they also found out some independent risk factors for AKI, which I will be talking about in a little while. And this is from the same study that I explained earlier. Then they looked at the severity of AKI and the outcome in COVID-19 patients. And as you can see, the patients, the mortality increases with the severity of AKI. And this is a systematic review and a meta-analysis, which included 53 published and 1 preprint study, which comprised 30,657 patients. And they looked at the pooled prevalence of AKI in these hospitalized COVID-19 infected patients. And the results were quite similar to the previous study that I mentioned. And they found out that about 30% roughly patients who were hospitalized with COVID-19 infection had acute kidney injury. And this percentage went up to about 46% if they were admitted to the ICU. And about 9% of patients who were hospitalized with COVID-19 infection received kidney replacement therapy at some point, and about 19% of patients who required intensive treatment required kidney replacement therapy. So what are the potential risk factors for COVID-19 related acute kidney injury? So they can be broadly categorized into 3 sections: the demographic risk factors, the risk factors for AKI at admission, and the risk factors for AKI during hospitalization. So the demographic risk factors include older age and other comorbid illnesses such as diabetes, hypertension, cardiovascular disease and congestive cardiac failure, high BMI, especially obese people, and patients who have baseline chronic kidney disease on admission, and certain genetic risk factors such as APOL1 genotype and who are immunosuppressed and who are taking immunosuppressive medications, and smoking. So the older age and other comorbidities, why are they more prone to develop COVID-19 related AKI? So it may be related to their poor functional reserve and inability to increase their EGFR in response to stress and poor nephron mass. So these may be the reasons why older age and patients who have other comorbidities are at a higher risk of COVID-19 related acute kidney injury. So what are the risk factors of acute kidney injury at admission? So severity of COVID-19, degree of viremia, and if the patient has non-respiratory organ involvement, leukocytosis, lymphopenia, elevated markers of inflammation such as higher levels of ferritin, CRP, and D-dimers, coexistent rhabdomyolysis, hypovolemia and dehydration, and certain medications such as ACE inhibitors and ARBs, and also NSAIDs may contribute towards the development of COVID-19 AKI. And what are the risk factors for AKI during hospitalization? So most of these patients who clinically deteriorate need contrast-enhanced CT scans, and they receive contrast medium. And also these patients are on vasopressor support most of the time because of low blood pressures, and they are usually mechanically ventilated. And all these factors will contribute towards the development of COVID-19 related AKI. So briefly, to look at the pathophysiology of COVID-19 associated AKI. So this is a slide that we all are familiar since medical student days. So the acute kidney injury is basically classified into 3 types: the pre-renal, the intrinsic, and the post-renal AKI. So the intrinsic AKI is again divided into tubular necrosis, interstitial nephritis, glomerulonephritis, vascular syndromes, and intratubular obstructions. So all of these may play a part in the development of COVID-19 associated AKI, which I'm going to explain in my next slide. So this is how AKI occurs in patients with COVID-19. So there are many pathophysiological mechanisms explained in the current literature. So as I mentioned earlier, pre-renal AKI can occur in patients with COVID-19 very commonly, because most of these patients have high-grade fever on admission, and they have a higher insensible fluid loss. And about 10% of patients who have COVID-19 have some form of gastrointestinal symptom, such as diarrhea, nausea, vomiting. So their intake is poor, they vomit most of the time, so they're hypovolemic. And most of the time when the patients are hospitalized, they are on high-dose diuretics, and overdiuresis also may play a part. And these are the main reasons why a patient would develop pre-renal AKI. And apart from that, as I mentioned earlier, COVID-19 is a multi-organ disease. So it can affect heart, it can affect the liver. So cardiorenal and hepatorenal syndromes can play a part in the development of pre-renal azotemia in patients with COVID-19. Acute tubular injury. So this is the commonest form of kidney damage in patients who are infected with COVID-19. And it's shown that about 60 to 70% of patients with AKI do have underlying acute tubular injury. So what are the causes of acute tubular injury? So prolonged hypoperfusion and prolonged states of hemodynamic instability can cause ischemic type of acute tubular injury in patients. And also when this virus infects the type 2 alveolar cells of the lungs, they recruit a lot of immune cells and release a lot of cytokines, which can cause circulatory collapse, low blood pressures, and again ischemic injury to the proximal tubules. And also, some of these patients end up having rhabdomyolysis with myoglobin cast nephropathies, which can cause tubular injury. And most of the patients with COVID-19 also have secondary bacterial and fungal infections, which might give rise to septic shock, hemodynamic instability, and again ischemic injury to the tubular epithelium, which will eventually give rise to acute tubular injury. And sometimes this virus can cause endothelial damage and can result in a thrombotic microangiopathy, which can result in renal infarctions and renal damage. I'll be talking about the glomerular involvement of COVID-19 in my next few slides. So I'm not going to talk about these, but there are a lot of underlying glomerulonephritis associated with COVID-19 that can contribute to acute kidney injury in patients. And sometimes this COVID-19, this AKI could purely be medication-induced. Some patients take high doses of vitamin C, which can give rise to oxalate nephropathy. And these patients are on various antibiotic combinations for treatment of secondary bacterial infections. So they're on vancomycin, they're on aminoglycosides, piperacillin, tazobactam, colistin. So all these antibiotics can cause interstitial nephritis and medication-induced nephrotoxicity. And can COVID-19 affect the kidney directly? There are reports in which, or there are case studies, case reports, which suggest that the virus can directly invade the kidneys because the virus usually binds to the ACE2 receptors in the lungs, and kidney, mainly in the proximal convoluted tubule and in the podocytes, these ACE2 receptors are found, and it is believed that this virus may have direct viral effects on the kidney. So what are the modes of renal damage? I think I've already talked about most of these except organ crosstalk. So This is a multi-organ disease, so sometimes when one organ dysfunctions, the other organ can get indirectly involved. So one of the common examples is cardiorenal syndrome that we see in patients with COVID-19, because COVID-19 is well known to cause myocardial injury, myocardial damage. So this can give rise to cardiorenal syndrome, organ crosstalk, and renal damage. So I think I've mentioned the other things that I've mentioned on this slide. We've talked about those. So what are the histopathological patterns of renal lesions by this virus? So we've talked about the tubular injuries briefly. So what are the glomerular lesions? The commonest glomerular lesion that they found in patients with COVID-19 was collapsing segmental and focal glomerular sclerosis, which is called collapsing nephropathy. I think you may have heard of this entity. This is something which is commonly seen in patients who are infected with HIV. So this was known as HIV or HIV-associated nephropathy. So there had been a lot of reports recently showing that collapsing nephropathy is a common glomerular finding in patients with COVID-19, and it's now termed as COVAN or COVID-associated nephropathy. And apart from this collapsing nephropathy, there are other glomerular lesions that can be seen in patients with COVID-19, such as minimal change disease, IgA vasculitis, SLE, membranous glomerulopathy, and anti-GBM glomerulonephritis. And as I mentioned, it can cause vascular lesions such as TMAs, renal infarctions, and we've talked about it in our earlier slide. So this is a study which was published recently to find out the etiology of COVID-related AKI. And as you can see, majority of cases were due to either ischemic, toxic, or combined ischemic toxic acute tubular injury, and that contributed to about more than 70% of cases. And de novo glomerular disease was only responsible for 2.5% of cases, and out of that, collapsing glomerulopathy was the commonest. So this is a H&E staining of a proximal tubule, which shows loss of brush border, and there's flattening of the tubular epithelium, distension of the tubules with some vacuolar degeneration, which are indicated by the arrows, and you can see necrotic epithelial debris in the tubular lumens. And this is a classic picture that you can see in patients with acute tubular injury related to COVID-19. And this is a similar picture where you can see distension of the tubules with very flattened epithelium, loss of brush border, and there's some evidence of collapsing glomerulopathy here. I'll be talking about this in a little while. So this is what we talked about. This is COVID-19 related glomerular injuries. And a little bit about collapsing glomerulopathy. So what is collapsing glomerulopathy? So it's a distinct and an aggressive form of focal segmental glomerulonephritis, where you see collapsed glomerular tufts and also hyperplasia and hypertrophy of podocytes. So this was initially described in various viral illnesses such as HIV, parvovirus, cytomegalovirus, Epstein-Barr virus, and other autoimmune diseases and malignancies, but it's now commonly seen in patients who have COVID-19 and also who are of African ancestry and who have high-risk APOL type genes. So this is a classic H&E. This is actually a silver staining of a biopsy sample where it shows collapsing glomerulopathy, where you can see the glomerular tuft is collapsed here, and there's evidence of hypertrophy and hyperplasia of the podocytes. And this is a classic picture of collapsing glomerulopathy. So what can we do to prevent and manage COVID-19 related AKI? So this is a consensus statement which was published very recently by the ADKI work group. And let's go through the recommendations given to us by this consensus statement. So patients should be monitored for AKI throughout their hospital course, because AKI is very common in these patients. And when feasible, renal histology should be done in patients, specifically in those who show heavy proteinuria, because that may help us to differentiate the potential causes of AKI and manage them accordingly. There's no specific evidence to suggest that COVID-19 AKI should be managed differently from other causes of AKI in critically ill patients. So most of the measures recommended by KDIGO and other relevant guidelines can be used in the management of COVID-19 patients who have AKI. So these are the potential management strategies for AKI. I'll be discussing each of these in detail. So standard of care to prevent and manage multi-organ failure, and measurement of kidney function regularly. So serum creatinine and urine output are the current gold standards for the evaluation of kidney function, but neither is specific or sensitive for detection of early kidney injury, because there had been case reports where patients had proteinuria and hematuria suggestive of renal involvement without rising creatinine or reduction in the urine output. So these are very insensitive markers, but these are what we have at the moment. So monitoring of kidney function using creatinine and urine output should be done in all patients who are hospitalized. And hemodynamic optimization is essential because hypovolemia, hypotension, and vasoplegia may occur in patients with COVID-19. So fluid and vasopressor resuscitation should be done to maintain their blood pressures, because that will optimize the renal perfusion, but that should be done using dynamic assessments of the cardiovascular status. And what fluid is recommended? So the composition of crystalloids fluid volume expansion is important, and it's recommended that balanced fluids are used for initial volume expansion, and they do not recommend normal saline for the expansion of volume in these patients with COVID-19 and AKI, especially patients who are septic, unless there's a special indication for the use of normal saline. So glucose monitoring is very important because most of these patients are hypercatabolic and they're on high-dose dexamethasone. So monitoring for hyperglycemia and use of intensive glucose-lowering strategies in high-risk patients is essential. At the nephrotoxin management and use of contrast media. So most of these patients, as I mentioned, are on various combinations of antibiotics. So it's we as nephrologists should make sure that they are on renal doses of these antibiotics, and contrast media use should be minimized. But if they are in need of a contrast study, we should make sure that they are given contrast prophylaxis before sent to the radiology department. So pharmacological agents, any evidence for antivirals? So evidence that antivirals may reduce the risk of COVID-19 is indirect and very limited. And immunomodulatory drugs, statin, systemic anticoagulation, ACE inhibitors or ARBs or NSAIDs do not show any impact on development or progression of AKI. So there are recombinant ACE2 and serine inhibitors which are currently under investigation, and there's no significant data available for use of these agents at the moment. Recommendations for renal replacement therapy use. So there's no difference in mortality or renal recovery associated with initiation of renal replacement therapy in the absence of emergent indications. This is a very common scenario that we face as nephrologists because we get constant pressure from anesthetists, physicians asking us to initiate dialysis. But the current data suggests that there's no difference in mortality with initiation of RRT in the absence of any emergency indications. But the decision to initiate renal replacement therapy should be individualized and should not be based on the serum creatinine on the urine output alone, because sometimes patients who are having hypoxemic respiratory failure, who are ventilated, might need dry lungs, and we might be asked to just do renal replacement therapy purely for the volume management. So that's why I said it should be individualized. So selection of modality. So the modality should also be individualized. A lot of these patients are on inotropic support. They're mechanically ventilated and on 2 or 3 inotropic support. So it's very difficult for us to put them on intermittent renal replacement therapy. So most of the time we go for prolonged modes of renal replacement therapy, such as CRRT, prolonged intermittent renal replacement therapy, SLED. PD is not commonly done in Sri Lanka in COVID-infected patients, but this is something that other countries practice. So if you are using CRRT, the modalities that they recommend are CVVHD or CVVHDF, because in CVVHD, they need lower blood flow rates, and it reduces the risk of circuit clotting. And if you use CVVHDF, this will reduce the filtration fraction and reduce the rate of filter clotting. So the dose of RRT, the delivered effluent flow rate should be 20 to 25 ml per kg per hour, with a prescribed dose of about 25 to 30 milliliters per kg per hour. And if the patient is on intermittent hemodialysis, minimum of 3 times a week hemodialysis is indicated. So vascular access, the right internal jugular access is the preferred site. And most of the time, these patients are put to prone position and they're usually hypercoagulable and they're obese, and this may all affect the vascular access performance in these patients. But if we can, and if we have resources, expertise, right IJV line is the preferred access site. So that's all about the AKI. Briefly, to touch upon the transplanted patients with COVID-19 and how do we manage them. So British Transplant Society and Renal Association has given us some guidance on the management of transplant recipients who are diagnosed with COVID-19. So this slide may not be very clear to you, but I'll just take you through this slide. So they have briefly categorized patients into 3 types: patients who do not require hospital admission, patients who are unwell and admitted to hospital, and also patients who are progressively unwell and require ventilatory support. So how do we manage patients who are unwell and admitted to hospital? Because this is the type of patients that we see in our day-to-day practice. So these are the recommendations. So they have recommended to stop the antiproliferative drug, which include MMF and azathioprine, and consider reducing or stopping the calcineurin inhibitors, which include tacrolimus and cyclosporine, and dexamethasone 6 mg daily for 10 days if the patient fulfill the criteria for dexamethasone, especially hypoxemic patients with saturations less than 94%. So remdesivir, although not used in Sri Lanka, may be considered in line with local protocols. And saturation, we should try and achieve saturations of about 92 to 96%. And we have to regularly observe them, especially for saturations, to monitor rapid deterioration. And we should make sure that they're not overloaded, but they're kept euvolemic. And we can stop ACE inhibitors and ARBs if they're at risk of AKI. And early prophylaxis for venous thromboembolism with heparin if there's no contraindication. And adjunctive antibiotics if superadded infection is suspected. And early discussions of seedings of care. So what should we do if they progressively become more and more unwell and require ventilatory support? Should we do something differently? Yes. So anyway, they've already recommended to stop the antiproliferative drug, but this is a time to dramatically reduce or stop the CNIs. Consider dexamethasone, as mentioned in the previous slide. And remdesivir may be considered in line with local protocols. And we use tocilizumab in some of our patients. Ventilatory support in line with local or national guidance. Adjunctive support or antivirals, and use of tocilizumab in sarilumab, which is not available in Sri Lanka in critically ill patients. So these are the drugs that are commonly used in other countries, but we don't have most of these. What we have is tocilizumab, and we've given it to some of our patients with good outcomes. So guidance on transplantation when prospective donor or the recipient has a diagnosis of COVID-19. There's no the evidence is actually scarce, but this is a statement which was released by the Indian Journal of Transplantation recently. So what they recommend is the patient should have complete resolution of symptoms for at least 28 days. They should have 2 negative PCR tests, including 1 negative test at the time of transplant, normal CT chest within the last 24 to 72 hours prior to transplantation, and adequate pre-transplant screening with multidisciplinary team involving cardiopulmonary specialties. And COVID-19 vaccination to be given to all transplant recipients and their household members. And this is the ISOT consensus statement for kidney transplant recipients and living donors with the previous diagnosis of COVID-19. So vaccination. Should we vaccinate our patients with CKD? Yes. But this is a systematic review which was done recently to show the immune response to this vaccination among patients with CKD. And you can see that about 74% of patients with chronic kidney disease will show immune response to the vaccine after 2 doses. And it reduces about, in dialysis population, after 1 dose of vaccination, the response is about 45%. But after 2 doses, it goes up to about 89%. But in transplanted patients who are very immunosuppressed, have low rates of immune response. About 8% of transplanted patients respond to the vaccine, to 1 dose of vaccine, and after 2 doses, about 35% of patients develop an immune response. So the NHS Blood and Transplant and the British Transplantation Society recommend that unless any other health contraindication exists, all patients who are on the transplant waiting list, and transplant recipients should be vaccinated with 2 doses. Are NIH guidelines different? No. What they recommend is all candidates should receive the vaccine while they're awaiting the transplant. And in general, vaccination should be completed at least 2 weeks prior to solid organ transplant or started 1 month after solid organ transplant. And in certain situations where patients receive antithymocyte globulin or rituximab, we can delay vaccination for about 3 months. And after completing the vaccination, it's essential that all these immunocompromised patients should continue to exercise precautions. And very briefly about timing of vaccination in patients who are on immunomodulatory therapies, because most of our patients have underlying glomerulonephritis who are seen in our vasculitis or in the low clearance clinic. So it's essential that we know when to vaccinate these patients. If they're on HCQ, IVIG, or glucocorticoids with a prednisolone equivalent of less than 20 milligrams a day, no modifications are needed. You can vaccinate them. If they are on sulfasalazine, azathioprine, oral cyclophosphamide, no modification to either immunomodulatory therapy or vaccination timing is needed. But if they're on mycophenolate and assuming the disease is stable, you can hold MMF for 1 week following vaccination. Cyclophosphamide, so it is a bit different, and they recommend the time of cyclophosphamide administration so that it will occur approximately 1 week after each vaccine dose when feasible. And rituximab, so assuming that patient's COVID-19 risk is low or is able to be mitigated by preventive health measures, you can schedule the vaccination so that the vaccine series is initiated approximately 4 weeks prior to the next scheduled rituximab cycle. And after vaccination, you can delay rituximab administration 2 to 4 weeks after the final vaccine dose. But this is all if disease activity allows. So 1 or 2 slides about post-acute COVID-19 syndrome. So what is post-COVID-19 syndrome? So usually acute COVID-19 lasts for about 4 weeks from the time of onset of symptoms, beyond which replication competent SARS-CoV, the COVID virus, has not been isolated. But post-acute COVID-19 is defined as persistence of symptoms or delayed or long-term complications beyond 4 weeks from the onset of symptoms. And this picture will summarize the effects of this post-COVID-19 syndrome. A lot of systems can get involved, and kidney is one of them. So the recommendations is that although resolution of AKI is anticipated in most patients with acute COVID-19 related AKI, some patients might not completely recover from their acute kidney injury because some studies have shown that reduced eGFR had been reported even at 6 months follow-up from the time of discharge. So therefore, it's essential that these patients are followed up in clinics to see whether their eGFR improves or whether they develop CKD following the COVID-19. So it's essential that multidisciplinary involvement and various teams should get together, and these patients should be followed up regularly for at least 3 to 6 months to see where they're heading. So that's all from me. Thank you very much for listening. Now I'm happy to answer any questions.
Thank you, Chathurika, for that excellent overview of COVID and kidneys. Thank you.
Thank you, sir.
Thank you very much, Chathurika. We haven't had any questions from the audience, so perhaps we'll have some posted online later. Thank you very much. Token of appreciation. So thank you very much, everyone, for listening. I'd like to finish by thanking my colleague, Dr. Anura Hevagigana, President of the Sri Lanka Society of Nephrology, for joining us today, and special thanks to the College of Nephrology, the Society of Nephrology, for collaborating with the Ceylon College of Physicians on these sessions. There are also a few people I'd like to thank, the staff of the ClinMark for providing the venue, and the audiovisual team today. Dr. Nalaka Herath from the Ceylon College of Physicians, who coordinated this session, and the staff of the CCP. And also the Young Physicians Forum was sponsored by Cipla Pharmaceuticals, and this college lecture was sponsored by George Stewart Health. Thank you very much.